Hello, my name is Dirk Schadendorf. I'm professor for dermatology and my special interest is skin cancer. I'm working at the West German Cancer Center in Essen, Germany, which is a specialized center on skin cancer. We are seeing a lot of melanoma patients from the very beginning, primary melanomas to metastatic disease, but also Merkel cell carcinoma, advanced squamous cell carcinomas. We're doing surgery, lymph node dissection, and systemic treatment. I'm here in Rio at the second Melanoma World Society meeting, and I would like to give you a brief wrap-up on targeted therapies. Targeted therapies are meant treatment of patients with melanoma carrying a BRAF V600 mutation. Roughly 40% of cutaneous melanoma do carry such a mutation and are eligible for treatment using a BRAF and MEK inhibitor. The combination of a BRAF-MEK combination is a standard for those patients. That's what we have learned over the last 5-6 years. We have various combinations of a BRAF and a MEK inhibitor available at the moment. Vemurafenib and cobimetinib as one combination, dabrafenib and trametinib as the second combination, and a third combination is soon being licensed during the next 12 months, will be encorafenib and binimetinib. Altogether, we know that this combination in patients carrying a V600 mutation will elicit around 70% of overall response rate. These clinical responses are fast in their onset. They're controlling disease for some time. The median duration is between 12 to 15 months. That's what we know from the clinical studies and the follow-up of these studies. And we know also that the median overall survival ranges between 2 to 3 years using BRAF-MEK inhibition. The toxicity profiles between the three combinations are slightly different. Clinical efficacy in terms of overall response rate, progression-free survival rates at, let's say, 1, 2, and 3 years, and also overall survival rates after 1, 2, 3, and 4 years are comparable. What we know is that BRAF-MEK inhibition is working in all patients, independent on their profile, whether they have a low-risk profile in metastatic disease, which are patients with normal LDH. These are the patients who are benefiting best. That's what we have learned over the last years. We can expect that patients with normal LDH at start of BRAF-MEK inhibition have a survival chance already now to survive 5 years in the range of 40 to 50%, which is quite amazing thinking back a decade back, that those patients have a survival chance of less than 10%, surviving 5 years at that point. Also, patients with more advanced disease will benefit from BRAF-MEK inhibition. For example, patients with brain metastasis also have a benefit. Problem is that increasing LDH, increasing also tumor burden, also the number of tumor organs involved is reducing the chances that there's a long-term benefit. Interestingly, long-term benefit in patients treated with BRAF-MEK combination seems also to be associated with tumor mutational burden, which is an interesting phenomenon and gives a basis to combine BRAF-MEK combination with checkpoint blockades. And first registrational studies combining these treatment modalities are underway. We have to wait for the clinical results to see whether this is the next step forward.